I would like to welcome you all to the Audit and Feedback seminar for the National Antimicrobial Stewardship seminar series. I'm really excited about today's session. I think it's going to be a really great session. My name is Misha Devchand. I am a PhD candidate with the National Centre of Antimicrobial Stewardship. I'm also an AMS pharmacist at the Austin Hospital in Melbourne, and I also work at Safer Care Victoria. I'd like to start today with an acknowledgement of country. I would like to acknowledge the traditional owners of the land I am on today, and that is the Wurundjeri Woi-wurrung people of the Kulin Nation, and pay my respects to their elders past, present, and emerging. I'd also like to acknowledge all of the traditional custodians from which everybody online is dialing from today, and also pay my respects to their elders past, present, and emerging. Today's session will be recorded and made available on the NCAS website after this session. We ask if you have any questions, there is a Q&A box just down the bottom of your screen. Please pop them into the Q&A box. Alternatively, if you would like to speak live, please just let us know in the chat and we can pop you on and give you access to that. We have discussed it with our amazing speakers today, and we've decided to do a combined question session at the end. So please just post your questions in the question and answer box, and we will get back to them at the end of the session. So I'd now like to introduce our first presenter, who is Mark Rigby. So Mark Rigby is the Director of Victorian Infection Prevention Services. He has worked in healthcare for more than 20 years, initially as a hospital pharmacist before transitioning into infection prevention and control consultancy. Mark holds a graduate certificate in both clinical pharmacy and infection prevention and control, and provides infection prevention, antimicrobial stewardship, auditing and quality improvement services across hospitals, day procedures, community health and residential aged care facilities throughout Victoria. Drawing on experience from hundreds of audits and quality improvement projects, Mark has a particular interest in translating infection prevention principles into practice, achievable improvements for frontline healthcare workers. He currently provides antimicrobial stewardship, auditing and benchmarking services to numerous aged care providers, and works closely with organisations to improve compliance and engagement and patient outcomes. Thanks so much, Mark.
Thanks, Misha. That was very kind. I'm going to start sharing my screen. Okay. Is that all good?
I can't see it yet, Mark.
No. Okay. No. There we go.
Perfect.
You can see that now?
Yes, that's perfect.
Okay. Sorry. So I'm just messing around with my browser a little bit here. Sorry. Pardon me. I've lost my I've lost my slides at my end.
Oh, okay.
I'm just
Yep.
going to stop sharing for a second.
Okay, cool.
All right. I'm very sorry about this. All right. That should be it now.
Perfect. We can see those, Mark.
Okay, so first of all, I'd like to thank NCAS for asking me to talk to you all today. I'm going to talk about the part of auditing that I think is often undertaught and underestimated, which is delivering the actual feedback. My experience has shown me that the real challenge is that the audit itself is only the starting point. The real work in how we communicate the findings in a way that people can hear, accept, and act on. So this session is about turning audit results into better practice and what has worked for me so far. I'll start with a bit of context about where I'm coming from. I started as a clinical pharmacist and then I moved into infection controlled consulting just before COVID began. And along the way, I started doing antimicrobial stewardship audits. This was not real-time clinical intervention. It was mostly the retrospective type, so typically doing things like the various NAPs. I've done this in both hospitals and aged care, and I've found that they're both very different environments. What I discovered pretty quickly was that, especially in aged care, the audit was the easy part, and certainly easier than in hospital settings. But it's giving the feedback that's the hard part. The problem most of us face when we audit is we already know what good prescribing looks like. We know the guidelines, we understand resistance, we understand AMS principles, and we know why antibiotic prescribing is a problem. But pointing out the evidence of inappropriate prescribing doesn't seem to change the behavior of those who actually do the prescribing. One thing infection prevention and antimicrobial stewardship have in common is it's largely about changing what people see as normal. Early on, I assumed that if we simply provided the evidence, prescribers would see the wisdom of our words, and because they're rational, intelligent actors, they would change their prescribing habits. However, I was wrong. I've since taken the view that people need to be convinced that there's a real problem worth fixing and accept that they have a role in changing it before they will invest any energy in changing their habits. As with anything in life, I think it's a good idea to know what roadblocks we're going to run into when we want to try and achieve something. These are the roadblocks I think that most of us run into again and again when it comes to AMS. First of all, prescribers are generally very busy people. They often already know antimicrobial resistance is an issue, but they may not feel it's the most urgent problem in front of them, and they may not see it as much of a priority and therefore don't dedicate a lot of their effort to it. Many already have a ready set of explanations for why their prescribing makes sense to them. Um, these are the ones that we always hear. I've been doing it for years. It has never been a problem before. My experience is my evidence base. I use my clinical judgment. I would rather err on the side of caution. None of these responses mean that the prescribers are deliberately bad or careless. They're usually intelligent, experienced clinicians defending their familiar practice, but it's usually in a system where there's limited accountability. So the question becomes, what is the point of doing the audit? Yes, we need to identify inappropriate prescribing, but why exactly are we identifying it? I think it's important to remember the goal is not to simply produce just a list of their mistakes. The goal is to facilitate an improvement in antibiotic prescribing. It's quite easy to identify problems after the fact, but it's much harder to convince an experienced clinician that the change is needed. That means that our role is not just technical, it's also about influencing communication and helping the organization create conditions where better prescribing becomes the norm and is expected. One of the most important lessons for me is to frame this as a systems issue, not about apportioning blame to individuals. I try to present the results to the whole organization whenever I get the chance. So prescribers, executive nurses, and anyone with any governance responsibility. This usually happens in either a MAC or a clinical governance committee. The reason I do this is it creates a sense of shared accountability. I explicitly reference the relevant standards, including the clinical care standards, the strength and aged care standards, as well as the ETG, so that everyone realizes that it's guideline driven and not just my opinion. I've found that the standards are placing an increasing emphasis on organizations having a demonstrably effective AMS program that is driving better prescribing. So if I can emphasize that, it helps shift the conversation away from, Dr. Smith just made a bad prescribing decision and towards how can we support the prescribers so they have what they need to prescribe closer to the guidelines. I've found accreditation is also a useful thing to take advantage of, and it helps AMS be taken seriously. And impending accreditation really creates a sense of urgency. I like the phrase, never waste a good crisis. During accreditation, the staff who are responsible for governance become sensitive to all their potential gaps, and they're worried that things like this might be picked up. So I think it's a very good opportunity to include AMS reports in the standards portfolio and actively point out where the organisation may have some weaknesses. and also be there to help with some helpful strategies to improve their prescribing. This has been a time where I can really grab their attention, and it has tended to create a lot of conversations at the sites that I look after. Written feedback. I feel that written reports matter because it becomes part of the permanent record. Um, it needs to be clear enough, the feedback needs to be clear enough that someone who is not in one of the meetings that we have can still understand the problem, the risk, and see the recommended actions. Basically, what I've done, I've adopted the hospital NAPS appropriateness scale to aged care AMS audits, so that rather than just pointing out errors or percentage of things that are wrong, I was able to provide objective data on appropriateness of individual prescriptions, which is something that I think aged care NAPS does not easily capture. I try to give the prescribers the benefit of the doubt when auditing, in instances where it seems like a reasonable decision in a difficult or complex situation, as I feel that they may be more receptive to the more obvious prescribing errors if they feel that their clinical judgment is respected on the hard stuff. Where prescribing is inappropriate, I provide a short but detailed account of the situation and how it deviates from the guidelines. I try to put it in terms that even a non-clinical person can easily ascertain what it is that I'm pointing out as the problem, so that it's accessible to executives as well as prescribers, and everyone feels involved in the feedback. I really try to avoid vague language like consider reviewing practice and things like that when the finding is actually much more direct. I report what the issue is in the context of the infection being treated, why it matters, and what the guidelines indicate optimal prescribing would look like in that situation. If appropriate, I also like to insert screenshots from the ETG to reinforce the message. I aim to write in a professional but a fair way, but not softened to the point where the message disappears. It still has to be framed as something that can be improved. I think if you can present the information in an objective and supportive way as possible, the people reading it are more likely to accept it as something that might be a helpful document rather than just a list of their errors. Another thing that I've found is when it comes to providing the feedback itself, there is actually strength in numbers, but in this case, I think it actually pays to be outnumbered. I find that when there's quite a few prescribers in the room, it is generally more effective to provide it as a group rather than one-on-one. Um, this is not to embarrass anyone. What I've found is that in a group feedback situation, without naming names, it makes it all less personal and more about the system. Um, the evidence seems to carry more weight when there's more prescribers, executives, nurses, and whatnot in the room. And the individual prescribers tend to object less in front of their peers, particularly in aged care. Um, I make a point not to identify who prescribed what. I find that anonymity helps because the prescriber who may remember prescribing that particular antibiotic might be slightly less swayed if a bunch of their peers are nodding along in agreement that it is an example where we can improve. And it helps everyone sort of absorb the message that we should be doing guideline-based prescribing. I still think that one-on-one discussions have a place, but if the aim is organizational change, what I'm really trying to do is organize a discussion or facilitate a discussion between people who have responsibility for governance, so like the executive or people like that, and those who are responsible for practice, so the prescribers. Uh, Having said that, I do avoid being used as a weapon. Sometimes a facility will ask, can you go and have a chat with Dr. Smith about this or that? I've found that that has never had a productive outcome. So I tend to try and avoid those discussions if I can. However, if the individual prescriber themselves approaches me, I'll always make time to have the discussion with them. When it comes to presenting the recommendations, I think it's very important to triage them. I always lead with the biggest issues first because those are the findings that establish that there are real problems that we should be worrying about. I tend to find that trends matter more and capture more attention than just isolated deviations. So if there are several examples of the same habit, I try to package them together so that people can see the pattern and it demonstrates a systemic issue rather than just picking at random transgressions. Minor single case guideline deviations might be technically correct, but they are often not the best opening move. I try to save them up for later when we've already established that there are some important and urgent issues and that people are a little bit more receptive to the other errors as well by that point. So my aim is really to create an urgency by identifying the clearest examples first, establishing there is something we can do to rectify these, and once there is an agreement, expand it to the prescribing that is less egregious. And previously, these things might have been just dismissed as nitpicking. I think it's very important that the feedback is actionable. I think it's no good telling them that they're just wrong. I try to make the statement of the issue very clear and unambiguous, and then I just relentlessly reference the guidelines. Particularly in aged care, I think a lot of their prescribing should be guideline based. This does two things. First, it shows that I'm being consistent and principled rather than just giving my personal opinion. Second, it puts the onus back on the prescribers to justify why they're departing from the therapeutic guidelines or the local guidelines. This still respects their clinical judgment, but it also respects evidence-based prescribing as well. If there is a genuine local reason to do something differently, I think that's fine, but I think it should be written into the local guidelines and supported by evidence. The various NAPs make room for local guidelines that are evidence-based, and we can audit to that. So I always explain this to the site and say that if you do want to do it differently and there's an evidence base for it, that's great. And I do offer to assist them with that process to create a local guideline and then audit to that. I do some benchmarking. I think benchmarking is a great thing to do because it shows everyone where the line is. I think humans in general, we tend to think we are better at things than the average person. And when you show people a line of where they're at, most organizations don't like being underneath the line. This is a demonstration of the last benchmarking thing that I did. I'm lucky enough to perform audits at about 13 sites at the moment that are all quite similar. So I benchmark these guys. I thought I would take advantage of having 13 sites and tap in the inherent need of managers and executives to avoid being below lines and start playing them off against one another and hopefully improve their prescribing. I find that benchmarking starts the conversation away with executives that individual case reviews simply do not and helps them take a bigger interest in the topic. They just tend to be more interested when there's a scorecard. It moves antimicrobial stewardship from being an abstract quality issue into something that's a bit more measurable. It also demonstrates that improvement is possible because if other services can achieve better results, they're naturally going to ask, why can't we? I think benchmarking has been a pretty valuable driver of change at many of my sites. So it's something I plan to keep doing. Also, I think management of expectations is something that we are responsible for as well. We know that there's going to be resistance to changing prescribing habits. That's something that we all know. This isn't going to change quickly because often these prescribing habits are heavily ingrained and reinforced over many years. And the effects of poor prescribing are not generally obvious in the short term. It's obviously more of a long-term thing. So it can be very hard for people, including prescribers, to make the connection between poor prescribing and increased microbial resistance. I think it's important for us to remember that our goal is not perfection after one audit cycle. I think we have to really communicate that what we're hoping for is incremental improvement over time. Can we be better than last year? Can we reduce the most avoidable prescribing errors? Can we strengthen governance and make expectations clearer so that everyone is on the same page? It's not always easy, but I keep encouraging everyone who's involved in the AMS effort within organizations to stay optimistic because I have seen that there is real progress happening, even though it feels like it's moving glacially slow. My audits have generally found that over the last 4 to 5 years, there has been an improvement in aged care antibiotic prescribing, at least in the sites that I do. I'm not yet confident enough to say that this is purely because of my auditing, but I like to think that that's part of the solution. Overall, I've been a pharmacist for about 20 years now, and I think I've seen a tremendous improvement in general health literacy, um, and an improved understanding of how antibiotics could be used, not just in the general public, but also in healthcare. It's just that it can be hard to see over shorter timeframes. So I like to keep reminding everyone who is involved in it that this is a long-term thing. We've got to keep at it, and we are fighting the good fight. The standards are placing an increased emphasis on AMS, and organizations seem generally more aware of their responsibilities around this, and I can only see that getting stronger as time goes on. Lastly, I think generational change is also starting to play a role as well. I'm tending to find that younger prescribers seem more aware of AMS principles in general, and are more open to evidence-based prescribing and accepting support from non-prescriber clinicians. So all that is to say that I think there are multiple reasons to believe that as frustratingly slow as the progress may seem, I think we are moving in the right direction. And as an auditor, I think part of our job is to keep people engaged. That's it.
Thanks so much, Mark. That was an amazing presentation, really practical. I really enjoyed it. We are going to hold questions over until the end of the presentation for our next presenter. But please remember that the Q&A box is available down the bottom, and please post all of your questions there. So I'm really excited to present Caitlin Chisholm. So Caitlin is the Antimicrobial Stewardship Infectious Diseases Pharmacist for Royal Darwin Hospital. She has experience working across the Northern Territory, both in Central Australia and the top end. Thank you so much for presenting today, Caitlin.
Hey, thank you. Let me just sort this screen out. Great. Okay. So hi, as already said, I'm Caitlin, and I'm the AMS pharmacist at the Royal Darwin Hospital. So my role is primarily based here, but I also cover sort of our entire what we call top end, East Arnhem and Big Rivers region, which is from here down to about halfway down the territory. So today I'm going to discuss a few of the things that make auditing and feedback challenging in the Northern Territory, some things I think we're doing well, and what the challenges are, and what I think we need to do better, and I imagine what a lot of other places need to do better too. So to just give everyone a little bit of an idea, I'll do a rundown of the territory first. So territory spans over 1.3 million square kilometres, has only just over 260,000 people, and for the entire territory has 6 public hospitals. So if you look at the map, up the very top in Darwin, we have 2 hospitals. If you follow the main road down to Katherine, we have one. Further down, we have another in Tennant Creek, one in Alice Springs, and then back up to the east, and in Nhulunbuy, there's a hospital there too. So these hospitals are really far apart. Some of them are very small, a couple of wards only. The one in Tennant Creek is a single ward hospital, and most of them don't have their own AMS or infectious diseases services. They're kind of all lumped in together with one of the larger hospitals. That being said, the main population in the territory is focused around Darwin and Alice Springs. So you do see most of the patients would go to those hospitals anyway. But we do have a really large span of area and lots of people who live in very small communities throughout the territory. And these communities will have varying levels of healthcare access. So the larger ones will have permanent clinics there that are open daily. Other ones will have clinics that are open sometimes, and even smaller ones too will just have visiting clinicians. So infectious diseases AMS here. We are a fairly, we're not a small service, but we're a fairly small service. So on the top end, based at the Royal Darwin Hospital, we have 2 IFD consultants on at a time, a consult service and an inpatient service. And then in central, there's a single IFD consultant on service at a time. AMS funding in the top end, I'm a full-time equivalent of pharmacist, and then I have 0.5 full-time equivalent consultant IFD specialist, which is spread actually across 3 different people. And then in Central Australia, it's just a 0.5 FTE pharmacist, and everything else has to be picked up by the IFD team. So this can make trying to arrange auditing and feedback really challenging, because it is a really small team, and because these teams are based exclusively at the 2 largest hospitals. Palmerston, which is up here in Darwin, gets visited once a week, but everyone else is phone service only. So it does end up in a system where you can find that hospitals are working really isolated from each other, that practices get really embedded before you realize that that's what people are doing. You can, if you're not paying attention, you can discover that a single person's prescribing preferences has sort of all of a sudden become the standard at a whole hospital. And then once it's embedded, it can be really challenging to manage. What makes the NT unique? We don't have any single one thing that makes us unique, but it's the combination of everything. So disease-wise, we have different diseases here often than other places. Melioidosis is a really big one. We get a lot of other things like dengue. We have a diphtheria outbreak. We still have really large numbers of tuberculosis compared to other states. We have been getting really resistant bugs, similar to other places, but we are sort of ahead of the curve. We've got down in Central Australia, nearly 50% of our staffs are now MRSA. Unfortunately, we also have animals, which always make our job tricky: crocodiles, jellyfish, the likes. And then we also have a lot of disease of overcrowding and poverty. So rheumatic heart disease remains a really big problem here in the Territory, which obviously can lead to a lot of other healthcare problems. Scabies is really endemic in the Territory, and we do see a lot of morbidity secondary to like chronic crusted scabies. And then we also have a high burden of immunocompromising disease. So CKD, type 2 diabetes, we have high lupus rates in the top end as well. So the reason I bring this up is that the Territory can feel really unique. And so for a lot of clinicians, if the feedback you're giving is very generic, if you're trying to provide research that is exclusively done elsewhere in the country or overseas, people can feel pretty confident that it might not be relevant to them, or they can, you can provide all the evidence for how things are done elsewhere. And if people are not convinced that it will benefit their patients, people won't make those changes that you want them to. So challenging when we're talking about auditing and feedback, things that make it tricky. One is that large distance. And then on top of that, travel can be really tricky at certain times of the years. Roads can be closed for months at a time. We often get water over a lot of our crossings, as shown in the picture there. Our hospitals can get evacuated. So Catherine Hospital over the previous wet season was evacuated up here to the Territory, I think twice, due to flooding risk. And then when things like this happen, obviously AMS for a lot of people becomes a lower priority. And so trying to keep engaged with people, trying to make sure that patients are still getting the care that they need through all of these emergencies can be challenging. The other challenge for us is our high staff turnover. At smaller hospitals, people might come in for a single term and then leave, which is great opportunities for them, is great for the hospital, but it does mean that if you're not quick with your feedback after doing audits, that the staff that you're trying to explain the feedback to aren't the staff who were there at the time, and so people can feel maybe that the feedback's not relevant to them anymore. If they're not convinced, that if they're not making the same decisions, then that feedback isn't relevant to them, and you're telling them something that someone else was doing. The other thing that is challenging is out-of-date technology. So the Territory is partway through trying to implement a new IT solution, both for like notes for medication providing for everything, which has stalled, and then also our decision-making tool, which we based a lot of our guidelines around, was decommissioned a few years ago, and the new one is still in the process of coming out. And so you do find that people who are really keen to follow guidelines to do what they're supposed to do are met with these barriers of advice that doesn't actually help them anymore, referencing systems that don't exist anymore. So one of the things I think we're doing really well here is the implementation of virtual AMS rounds. So this is more informal feedback rather than formal feedback, but I've found that with the challenges that we have here in the territory, that this informal feedback has been really beneficial, and often we're seeing more changes from this than we are from our formal feedback from audits. So this is done specifically in the top end. This is done with Catherine Hospital and Grove Hospital fortnightly. So they take it in turns on a Wednesday afternoon. From here at Royal Darwin, it's attended by the AMS team, and then from the local hospital, the regional hospital, the medical team, the pharmacist, and if they have an infection prevention nurse, she comes along too. And also at times other teams will come too. So the surgeons down in Catherine will sometimes come in if they have capacity. We use this sort of as both a time to talk about specific advice around specific patients, but it's also an education opportunity as well. So both myself and the treating teams will bring with them sort of a list of patients that they feel need to be discussed. And then we can use this one to, as I said, make specific changes to specific people's medications, but also makes it really easy sort of to track trends and patterns in what decisions are being made around treatment of infections. So one that we see a lot is people who have been diagnosed with infectious exacerbations of COPD being sort of escalated to pneumonia treatment. I think this is a really common thing everywhere, but having these really regular meetings, you notice those trends, and you notice, I guess, when people are aware maybe that they're prescribing off guideline, but they're doing it anyway, and so it gives the opportunity to really focus in on why decisions are being made, and trying to, rather than just telling people over and over again that that's not what the guideline says, actually like listen, hear why things are being done, and try and change your feedback to feel more relevant, and to actually answer the questions that people have and the concerns that people have. Because of this is like low formality, quite casual at times meetings, I think a lot of people are more open to the feedback that they get. They are able to listen, they're able to make those changes, and I do notice over time changes to people's prescribing habits, or people even in expectation for those meetings, sometimes thinking beforehand and making those changes proactively that they know will be recommended. So pros of sort of this informal way of giving feedback. One is that on our wards, we have an electronic prescribing system instead of paper charts. So it means that in the moment, you're able to actually see what's being prescribed, what's happening. You're not relying on people trying to remember what they've given or what doses they've done, and so you can pick up errors more easily. And also, we're able to extract all that data from our prescribing system, Emma, into an Excel spreadsheet that gets emailed to me daily. So you kind of get a real-time-ish, like daily update on what antibiotics are being prescribed everywhere. And these consistent meetings have really helped build rapport. So our AMS team for a long time was a really stable group of two. And so they set up some really strong relationships with these smaller hospitals. And even now, as someone who's newer to the team and has come in only within the last year, that foundation is there. And so there's this inbuilt trust, which is making it a lot easier to give this feedback and try and change people's prescribing patterns. The difficulties, our EDs across the territory are still on paper charts, and so if you're not in person, it's really hard to engage in our emergency departments. So this is an area where we do need to do more formal auditing, because we know that our EDs are really high users of antibiotics. probably mostly appropriately. Our primary healthcare service can be really limited at times, and so people come to the EDs for things that they would maybe go see a GP for elsewhere. But it does mean that we know that there's a large amount of our prescribing that goes unseen. We know this from our NORSP data, which often shows, well, which always shows that the EDs in the NT are leading the way on antibiotic prescribing. Fortnightly does mean that you miss a lot of patients, and it means that this isn't an answer to, more traditional infectious diseases consults on looking at specific patients. And so looking at this more as an education opportunity rather than necessarily focusing too much on individual patients can be of benefit to try and get that long-lasting change. And the other is this limited capacity to review uptake of advice. So we've had an RMO working with us recently who was doing an audit of the top end and seeing how much of the feedback that we give in formal AMS rounds gets taken up. So that's still pending, but it will be quite interesting to get that feedback, to get that data and then to be able to feed it back into the teams. I think that we'll find probably actually that our remote regional hospitals are actually better at uptaking the advice than our hospital here. I think because I don't know, there's just a really good relationship there and a lot of trust there. And so when you give that advice, people are often listening really closely. So that was primarily looking at like a more informal way of looking at giving feedback and also at collecting, I guess, data, which leads us into actual auditing. So in the territory, as I've said, people can feel, and I think rightly so a lot of the time, that we have unique populations and that research that's been done overseas and in the rest of Australia may not apply. A big, I think maybe example of that is recently, not in a hospital setting, but in the community, the rollout of pharmacists prescribing of antibiotics for UTIs. A lot of states went with trimethoprim first line, but here in the territory, we already knew that we had about only 60% of our E. coli UTIs would be sensitive to trimethoprim, and so there was a lot of back and forth about whether we would roll out the national recommendations for trimethoprim first or whether we would make our own guidelines here. We did end up making our own guidelines, but it means that we are giving different advice to clinicians here than interstate, and so it means that then that feedback that auditing that's done elsewhere about efficacy of treatment, about how the program is going, isn't necessarily applicable here in the territory because we know that we're already doing different things than other states. And so it does mean that we need to focus more on our own auditing and our own research. Despite that, most of that is done in our main hospital. So Royal Darwin and Alice Springs Hospital is primarily where a lot of that research is focused, and our smaller hospitals are often missed in these things. So unfortunately, again, it's that layer on layer, and that these smaller hospitals can feel like none of the research and none of the auditing that's being done is relevant to them. So what can we do to improve that? Trying to get local staff engaged. So we have, as I've said, we've got really engaged teams, and so they've started doing some of those like smaller audits themselves. I know that our infection prevention nurse in Nhulunbuy and Gove has been looking into their ciprofloxacin prescribing because there was a time where we noticed a really sharp increase in use there, and so they took it upon themselves to along with us look into why that was and try and analyze that. I think if you get local teams engaged in their own prescribing and interested in trying to see why they do things, why they're doing the things they do, can make that change from those audits more beneficial because they're the ones who have identified a problem. They're the ones who have looked into things. And so the actual solutions, rather than feeling like someone coming in and telling them what to do, can feel like it's more organic clinician-led change. The other benefit of our virtual round is about that data collection. So we've got this sort of split electronic paper prescribing, but also like just in general, the patient information in the hospitals is split. So labs, letters and stuff are all online, but we're still on paper notes. And so if you're just auditing from afar, you can miss a lot of that information. And so you can have to sometimes make a lot of assumptions about why things are done. If you can see something's been prescribed, but you can't see the rationale for why it was prescribed, it can be really hard to do that auditing. So these rounds have been really beneficial in that you can then, in those things, in those meetings, gather some of that information there. And I found that particularly useful in our point prevalence, our NAPS surveys, which to be as robust as they are, can't just be from a single in-person visit, which we do. I will do a single in-person visit a year to these hospitals to do a little bit of data collection while I'm there. But that by itself isn't really a good overall picture. And so having these virtual rounds allows us to bulk up our data and find more patients and collect better patterns of prescribing, rather than feeling like you're coming in and looking at a single day and making a judgment on a whole system based on what happened on a single day. So that's been really beneficial too. Sorry, I've lost my train. But yeah, so this is, I guess, an area where I think we do need to do better, and that I am aware that still in the Territory at least, our auditing is still primarily focused on our major hospitals. And so trying to find better ways to more consistently get formal data rather than just informal data for our smaller hospitals is an area that we're still working on improving. And I think part of that will be further engagement with local staff to have more input into the auditing themselves. Ongoing concerns. Ours are the same as everywhere else, but it is the reasons why people may feel like the data that we give them is not particularly useful at times. We know our resistance rates are worsening. Our clindamycin resistance, our ESBL rates are really high, and we know that our primary one of our big drivers of that is oral antibiotics, both from EDs on discharge and from our primary healthcare networks. But that this isn't necessarily due to poor prescribing or incorrect prescribing, but unfortunately just due to the options that we have to treat the diseases that we have. And so trying to bring solutions to this that aren't just telling people to change behavior that maybe can't be changed is really a focus. Therapeutic drug monitoring, patients needing to travel far away from home, these things can make it tricky as well. But the reason I bring this up is the opposite, which is that even the data that we do collecting here, like audits you do at Royal Darwin Hospital, the patients who are here are also the patients that are in our remote hospitals. There's a lot of transfer in between the two. There's a lot of patients from there who will get flown in for treatment. And so if you can, so you can look still at data in your major centres, and you can still pull out your remote areas from that. The other thing is, is about, I guess, benchmarking. I thought it was really interesting, Mark mentioned before, how people can find benchmarking really motivating, and people can want to do better than the benchmark and prove that they're better. I sometimes see the flip side of that, which is that here in the Territory, hospitals are benchmarked against other states, and so people can look at the benchmarking and dismiss it wholesale as something that's not related to them. Oh, of course, hospitals in Queensland use less antibiotics than us. It's a completely different state. And so trying to balance that people's feeling of a unique system with the evidence that shows where we are truly unique, and where we should be looking to other states and trying to strive to mimic them, not mimic them, follow the trends that they're following. Yeah. Anyway, thank you.
Amazing. Thank you so much for such a great presentation, Caitlin. We are going to go into question time now. So what I might do is, Mark, I might start with you. Now, Caroline, I think you have a question for Mark.
Thanks so much, Mark and Caitlin, for two really, really fantastic presentations. They've been so eye-opening and really, really great to hear. Um, I have a question for Mark, actually. I'm really interested in your very unique perspective as both a pharmacist and an ICP. And obviously both are really, really important in AMS. I'm wondering if you can comment about if your approach has sort of differed now that you have that ICP training and if there's things that you can learn. I suppose sometimes we hear from nurses and ICPs that sometimes they feel like they're not, they don't have like enough knowledge or experience or expertise to be able to provide feedback in that setting. And I'm wondering if you could make a comment on that.
Yeah. I think, yeah, what I found is there not a reluctance, but yeah, there does seem to be amongst nursing staff a lack of confidence around doing things like NAPS and AMS involvement, that kind of thing. I think in a lot of ways for pharmacists, we can sort of be the accountants of the health world. So we see it, we love a good algorithm, love a good guideline. And it can just be, I think, exposure to that kind of thing. So sometimes it does take support, but they have generally have very good clinical knowledge. If you can really embrace the understanding how the therapeutic guidelines works, understanding what the particular disease is that you're looking at and how to navigate through the ETG, I think it demystifies a lot of it. So my background was oncology. So I spent 15 years as an oncology pharmacist and only really started doing AMS afterwards. So I think it's just being, if you do have an interest, it's being prepared to take the time, particularly in aged care, learning the basic ones, because a lot of it's empirical prescribing. And if you can get your head around those ones, then I think there's a lot that nurses, IPCs have to offer in that space.
Great, thank you.
Kaz, did you want to ask your question?
Yes, I just wanted to congratulate both Mark and Caitlin because they all brought out, the importance of building those personalized relationships, that handshake stewardship. You don't have to follow strict protocols, that you need to work to fit within the environment that you're working with. And I just think they were just both brilliant presentations. So, and I think hopefully everyone online will have learnt that. My question relates to how antimicrobial resistance has been sort of framed in Australia, and it's been completely tied to AMR. Now, to the average Joe on the ground, nurse, pharmacist, doctor, out and about out in working there, doing their practice, it is not something which is probably immediate to them. What is immediate to them is the fact that they don't want to miss sepsis. They want to do the right thing by their patient. And these days for me, I rarely talk about AMR actually, and my focus is 100% on patient safety. And I wonder, because some of you online will have heard me talk about this, but we talk about this concept of moral injury, where we're trying to do the right thing as a steward, but we're causing tension because we don't want to make them feel bad when they're actually trying to do the right thing. So just interested in hearing from both of you how you tackle that tension, because I think that is there. And the understanding that optimizing antimicrobial is more appropriate is going to have better patient outcomes. I'm interested in both of your thoughts around how you tackle that. Maybe Caitlin, because you're in the high risk environment up in Northern Territory.
Yeah, I'm happy to go first. Yeah, it is a challenge, and we do find that for a lot of people, yeah, you bring these conversations of antimicrobial resistance to them, and they care about it in theory, but they do find that, like, yeah, when the patient's in front of them, they want to make the decision that they think is best for the patient, which is completely understandable. part of it I find is focusing rather on, I guess, individual decisions, but and more on patterns. So if you're going to make a decision when a patient's in front of you to pick, I guess a really common one up here is picking Bactrim for a skin infection over something like Keflex. One, because if you don't know what the sensitivities are, hedging your bets. Or two, because in a pediatric sense, the liquid, Bactrim liquid, is shelf stable. You can keep it outside the fridge. And so you get a lot of people who go, I'm just going to give it because I know that I don't know if they've got a fridge at home, so we'll just give Bactrim. And so rather than looking at individual cases and trying to change their mind in every single opportunity, I'm trying to focus on having people consider, ask questions, look at individual patients before they make default decisions, and so going, okay, some patients you are going to have to choose Bactrim for practicality, for resistance, but can you think, look at each patient and as an individual, and rather than make assumptions. If you want to make the assumption that no one has a fridge at home, you're going to, give people a medication that does have harm to them. And so discussing what the risks are, why it would maybe isn't always the best decision, and giving people like those options. That's part of it. Also, I found that we've been getting a bit of success in personalizing resistance as well. So it's not just, if we give, we know that azithromycin use, for example, is driving clindamycin resistance in our staffs, which is something that we've been seeing throughout the territory. It's not just something that will happen theoretically on a population level. It's also something that might happen in your patient. Your patient is colonized with staph. They have limited oral options at the moment. If you give azithromycin, in 6 months' time, your patient in front of you might not have that oral option. And so part of it is that as well, is you're not just thinking about population level, you're also thinking about individuals and these patients that these clinicians have relationships with, and are you causing them personally harm by these decisions? And so I think that's of benefit too. Yeah.
Great. Mark, interested in your thoughts.
I feel I've got a much less complex problem to deal with than Caitlin does. For mine, I was worried about the what was the phrase you used, moral injury, earlier on. I've become somewhat less concerned with that now because I find that because it is mostly empirical treatment at the level that I'm dealing at, I feel there's less wiggle room for the prescribers to find their way out of it. And what I've found is sometimes it's just either a lack of awareness or they've effectively found a bit of a cheat code, So it looks like something respiratory. I'll give Augmentin Duo Fort. It's something skin. I'll give Kefalex and TDS. Sort of the things that I don't think there's a great deal of discussion that they could do to convince me otherwise. And I think deep down they know that what the issue is having a better awareness of the guidelines for the particular infection that they're treating and being more targeted that way. I'm always encouraging them to take specs, which is something I find, even though they should always be taking a specimen, it's not something that always occurs. But I constantly push that because whenever they do say, oh, I want to make sure I cover off everything, well, if you prescribe appropriately with the empirical treatment and you get your spec back, then you're still well within the boundaries of being able to escalate to whatever that bigger antibiotic is that you need. So yeah, I don't think I have to deal with the moral injury on quite the same level as Caitlin does. But I just try to frame it in such a way that, the guidelines are pretty clear, the prescribing's empirical. If you need to make a guideline, then you really should have an evidence base behind it and make a local guideline that you're prepared to stand by.
Amazing. Thanks so much. We've got a couple of questions in the Q&A, so I'm just going to quickly go through them as well. The first question is for Mark. Do you think strengthening incorporation of AMS pharmacist roles into into aged care could be the answer to some of these AMS issues?
I think it could, but I guess it's the same as anything. It's a question of resources and time. Um, Yeah, so I think now that, my understanding is that there is a lot more on-site pharmacist presence in aged care. So if there was a way to integrate it and there was a way to, because I don't think it's immediately being a pharmacist doesn't automatically make you an AMS expert. Sometimes, there is some knowledge that you do need to accumulate along the way. I'm not sure how strong that is out of community pharmacies, but if there was something targeted at maybe perhaps community pharmacies who have a bit more presence inside aged care, I think that could only be a good thing. Because I feel that in a lot of ways, the pharmacists who are visiting these places would be fine with, blood pressure stuff and, diabetes things. They're quite comfortable with all that. But for some reason, when it comes to antibiotics, my feeling is that their confidence tends to dilute a little bit. So if there was a way that we could get people to be more confident, then yeah, I think that would be ideal.
Amazing, thank you. Um, this question's for you, Caitlin. So you mentioned that about E. coli having different susceptibilities to trimethoprim in the territory compared with wider Australia. Um, and then you also mentioned about how that changed your community prescribing pharmacist program. Um, what have you changed to, and has that also had a flow-on effect to your hospital system?
Yeah, thank you. Yeah, so in the territory, I'm actually just trying to pull up our guidelines now. Yeah, so in the territory, when we were bringing in the decision for UTI treatment out of community pharmacies, at the time, the TG still recommended first-line trimethoprim for UTIs, and so that was what most of the other states did. And realistically, it's what a lot of our a lot of our GPs were prescribing too. But despite that, we had the susceptibility data in front of us that showed this really high resistance rate. And so there was a lot of discussions backwards and forwards between a lot of people about whether we should go with what the current guidelines officially said or whether we should do something unique. And so just to get the numbers for us, trimethoprim, yeah. So E. coli in the urine currently 56% are susceptible to trimethoprim. So we knew that we were getting if we brought in this program that for 50% of patients was not going to treat them. Because that was what the guidelines said elsewhere, because it was what was maybe being done already, that was going to be one, it was going to probably result in a failed program, right? You be like, oh, we brought in this new program and it's not helping people and it's not preventing people's GP visits, it's not preventing people from coming into the hospital. So the decision was made to put cefalexin kind of as first line for that. Our cefalexin sensitivity is not perfect, but it was better. Obviously, I think like elsewhere, nitrofurantoin would have been the best option, but there was we again have really high rates of chronic kidney disease in the territory, and so having to assess patients at the time they come in about their risk of CKD, do they have it, not know it, that sort of thing. It was decided that was too tricky to manage, and so cefalexin was our compromise. From there, what have we seen? I think it's hard. We were hoping that it would be easier to actually audit the program to see what people were getting and what was happening. And we are trying in our EDs to look at patients who have come in post failed treatment, but they will still miss all the people who have had successful treatment. The private nature of it has made it really hard to look into it. So we don't have really any answers for whether this has worked or not, unfortunately. But we think it has. We've at least got a drug that is being recommended that is practical to take and works more than it doesn't work. And so we're hopeful that is making a difference. And we've seen also the TGs now come along as well. So that change, we were ahead of the curve with that, but we have seen it happen elsewhere. Yeah.
Amazing. Thank you so much, Caitlin. I'm really mindful of time because we're at 9:30 now. So I just want to thank both of you. Your presentations were amazing. I think everybody definitely will have learnt something and has some take-home messages. And it was really nice, the consistency in messages that you both had. I thought that was really lovely as well. This recording will be available after the session on the NCAS website, so please just have a look there. The next session will be on Wednesday, the 23rd of September, and the theme is sepsis, which will be really exciting. Thank you, Mark. Thank you so much, Caitlin. We really appreciate having you both here. Bye, everyone.
Thanks, Misha.
Thanks so much.